I want to thank APT for this kind invitation. This is one of the last speeches. I will be fast, don't worry. I will share my experience about the APT devices, the wires, and the microcateters. These images from Mihailovic's book. As you see, we have lots of wires, lots of microcateters, and the question is, do we still need new devices for CTO and CHIP patients? I think this is the question, and my answer is yes. Why? Because we still have unmet needs. We still deal with very complex cases. Day by day, year by year, we are dealing with more complex cases, octogenarians, calcified cases, so we need better devices. And the second answer is, yes, maybe you have very good devices, but it's good to have alternative good devices in the market. Because in the COVID pandemic, we have lived very severe supply problem. In the healthcare issues, you shouldn't have supply problems. So it's good to have alternatives. And also the cost issues are important for most of the countries, not just for the third countries, also for the Western countries, the healthcare costs are going up. And if you have alternatives, we know from the market that the prices are going down. I will not go so much details about the wires and the micros. Many of the friends have told a lot about these. I want to give just one detail. The CTO wires 1.53 and 4.5 grams are polymer jacketed wires. But the only thing is the tip of the wires are not polymer jacketed. And it gives you a stability. I think these wires can be compared with the Pilot 200, with the Gladius, but the very tip of the wire is not polymer jacketed, as you can see from this picture, which is taken by me, and it gives you stability. It gives you the advantage of the stability, and it gives you the polymer jacket of the wire. The rest of the wire is polymer jacketed, and it gives you the advantage of the drilling, the surfing in the CTO body. I think I should directly get to my cases. We have talked about these details many times. My first case is an LED CTO. It's not a very long one, instant CTO. We tried Elong 2.6 French microcatheter, and we started with 3 grams H curve wire. These wires comes with H curve and straight ones in our country. H curves, of course, as expected, decreases the penetration force, but it gives you the advantage of find the right place to make a puncture. And in this case, we used it. As you see, the H curve wire is coming to the proximal cap. Then we took 1.5 gram straight tip, and it navigates some millimeters in this stand, but we had some knuckling, so we increased our stiffness. We get 3 grams straight Anyreach wire, and finally we could easily get to the distal, and the micro could easily cross the lesion, and we finished the case with drug-coated balloons. So we finished the case with Anyreach wires, 1.5, 3 grams, and 3 grams straight. You can use both the H curve and the straight ones, but the H curve may decrease your penetration force. You should keep in mind that point. This is another case, RCA CTO flash occlusion. It's so difficult case. It's impossible to engage through the right coronary artery. So we directly started with the retrograde way. Of course, we took Elong 2.6 French microcatheter because it was a long lesion, calcified lesion, so we need some force. Our septal crossing wire was Anyreach 0.3 grams, and it's nearly our daily routine wire. And as you see, it can cross all the septal channel in a few seconds. It's so easy. It's so easy for this wire, I think. And we could carry it up till the proximal part of the RCA. And it wasn't an issue for us to carry these microcatheter to the very proximal of the RCA, but the rest of the case was very difficult. It wasn't so easy to puncture the ostium of the RCA. It took maybe a few hours to get some wires. We have tried several wires. I think we caught the aorta, but we couldn't be sure because it wasn't looking so good. So we had to get our micro in, and then we did a tip injection from the aorta, and then we were sure about it, and we did the balloon, and rest of the part was just stenting. So the Anyreach 0.3 grams wires are really useful for septal crossing, and 2.6 French microcatheter along microcatheter can cross from very difficult scenarios. The third case is another RCA CTO case. As you see, it's a long CTO, it's calcified, it's ambiguous case, so it will be nearly impossible to finish this case by integrate. We have lots of branches distally. We didn't want to lose them, so we directly started from the retrograde way. Also, we had very good septal collaterals connecting to distal RCA. We directly started with 2.6 French microcatheter, and the wire was 0.3 grams. This time I took polymer jacketed one. It could be either the C1, which is not polymer jacketed, but both of them can work. Mostly we use polymer jacketed one for epicardials and very tortoise collaterals, but you can use them either. And as you see, we could cross the septal channel in a few seconds again. It was a bit tortuous septal collateral, so it took some time to cross with the microdistally. And with this micro, of course, you should be a bit patient. You should give some time. You should give torque. You can torque it in both sides, but I mostly prefer for clockwise turns. And at the end, we could get to the distal of the RCA, as you see. But the rest of the case was not also a piece of cake. We couldn't cross, integrate, or retrograde in the true way, so we had to knuckle in the both ways. We used 3-gram Anyreach wires to do a knuckle from the both sides. And as you know, they are polymer jacketed wires. You can do knuckles with these wires, and I think they are useful in that way. And so we did a reverse card, and we could catch the catheter with the 3 grams of Anyreach wire. And we finished the case with this way. Next case is a CIRC CTO, a post-CABG patient. It's calcified, and another problem is this patient had a stent in the left vein, so the micro had to cross this stent. So we discussed should we do a balloon before crossing this stent, but we didn't. We directly take along 2.6 microcatheter, and it easily crossed from the stent, and we could easily come to the proximal cap with this micro. For this case, we tried 2 wires, 1.5 and 3 grams Anyreach wires, but both of them were in the false lumen. We couldn't find the distal true lumen with them. Then we tried for the 6 gram. And as you will appreciate, the 6 gram could easily jump into true lumen from the dissecting site. And we confirmed with the injection that we were in the true lumen. And the rest of them was to carry the micro to the distally. As you see, there is some band here. It's a calcified. We had to cross the stent, but despite all difficulties, we could easily cross the microcatheter along 2.6 French microcatheter to the distal part. And we did ballooning and stenting, and this huge CX was saved with these devices. Next case is interesting. It's a very difficult RCA CTO. It would be impossible to do it by the antegrade way. But the retrograde way was also very difficult. We had a dissection in the left main. We had to put a stent during this procedure for the left main to cover this dissection. And as you see, we started with along 2.6 French microcatheter, but the problem was all the proximal LAD was very calcified, so it wasn't so easy to cross this micro. And even we couldn't get into the septal. We want to get these septal. So we had the options. We could do balloon and stent for the proximal LAD, then we tried, but with Dr. Şevket, we decided to give a chance for 1.9 French along microcatheter, which is not a torqueable one. You can maybe turn a few turns. It's so small, you cannot even see it. It's invisible, but it can cross in some scenarios, and this is one of it. As you see, it's coming, and we could get into the septal. And we did the injection, and we saw some connections. and from the right one, it's not so easy to see it. As I said, it's so small. Yeah, it is crossing to the distal. Yeah, it's invisible, invisible macro for invisible collaterals. But it could pass through the distal part. So in some scenarios, if it's so calcified, if you cannot cross with the along 2.6 French, then 1.9 French can be an option for these cases. Then we could get to the distal and finish the case. The next case is also another flash occlusion RCA. The last week I tried it. You cannot sit it. It's impossible to engage for the right coronary artery. So the only way was to try the retrograde way. I took 2.6 French along microcatheter. I directly took Anyreach 0.3 polymer jacketed wire. As you see, there is some bands there, a bit tortuosity, but we will cross it in a few seconds. Yeah, we are in the distal, and we could easily get to the distal RCA. And also we could easily carry the 2.6 French along microcatheter to the distal RCA, and we could finish the case by this way. I want to show you also another case about 0.3 grams. Yes, we use them mostly for collateral crossing, but moreover, we can use it for more complex lesions without CTOs. For instance, this is an LAD occlusion, subocclusion, it's retroflex, there is a plug in the distal left main. So I think workhorse wires cannot cross, maybe cross, but you should try a bit. In the past, maybe we would use polymer jacketed filter XTR or something like that. But these wires, as you know, can go subintimally. And if you go subintimally for this LAD, maybe you will lose the flow, lose the flow, and it could be complicated. Nowadays, I'm trying 0.3 grams for these indications. And as you see, it can easy close from this lesion, and you are 100% sure that it's not going subintimally. So you are in the true lumen, and it can cross the lesion. I think we can give an indication for these scenarios, and we finish the case easily with the left main standing. Another case for 0.3 grams. This is the CIRC CTO, intermediate artery is also occluded, and the LAD is also occluded. The problem with the LAD is that this LAD is so diffusely diseased, and so we cannot see it appropriately. So we could only feel it. And we used Anyreach 0.3 grams, and we tried many places to find the distal LAD. Luckily, we could catch the distal LAD, and then we did the balloon, and by this wire we could stand and we could treat the patient. Next case is for express main guide extension catheter. As you see, it's an LAD ostial lesion. There is some lesion in left main, and it's a very calcified circle lesion. At some point, we had to cross to circ, but most of the balloons could not cross for the circ. We did some ballooning in the proximal part, but it wasn't enough. We had to cross a bit bigger balloons and C balloons, and also for stents. And we had a wire in the LAD. We didn't want to lose it. What we need, we had to put a guide extension catheter for the circ. But with most of the guiding catheters, if you want to advance a guide extension, you had to take out the second wire. It's not possible to send the guide extension in all guiding catheters. You need bigger ones, maybe launcher can tolerate it. But for French express main guide extension can cross from all 7 French guiding catheters. Even you have a wire in the other vessel. In this scenario, we had a wire in the LAD. We advanced 4 French express main guide extension to the circ, and we could easily finish the case. What you can pass from this 4 French guide extension, even 3.5 stents you can pass them from this guide extension, and we could easily finish the case with the help of the 4 French express main guide extension catheter. And the last case is a very difficult LED CTO. He was a very unlucky guy. He had a stent in the ostium of the LED. Then he had a stenosis and he had a bypass to Lima to LED. But unfortunately, it didn't work. They put a stent from the left main Lima to LED distally, but it was blocked. So we had to open the all LED. So we had a triple access. One is from the right, left, and the Lima. We had to puncture from the ostium of the LED. We took 2.6 French guide microcatheter, a long microcatheter. We had to be very powerful at this point to make this puncture. We tried Anyreach wires, 3 grams. I think 6 grams didn't also work. We had to take Kocas Pro 12 to cross the proximal part of the stent. Luckily, we could cross. Then our micro is in also the distal part. We did some de-escalation at the distal part, but at the very distal part, the LED was diffusely diseased. It wasn't so easy to cross with the lots of wires. And we want to be in the true lumen because if we get into the subintimal space, distal LED will be disturbed completely. So we took 0.3 grams and it could easily catch the distal LED and we could easily finish the case. I think we did drug-coated balloon for all the LED and the result was perfect. And what are my impressions? First of all, 2.6 French along microcatheter is perfect. I think we all agree in that scenario. 1.9 French is also useful for tortuous, very tiny septals and for the tortuous vessels. And 0.3 gram wire is also a perfect channel crossing wire. And I think it's more than that. You can use for your daily complex cases like that I showed you as ostial LED lesion. And for the CTO wires, 1.53 and 6 gram wires, I think they deserve a chance for many CTO lesions. You can cross lots of lesions with the wires. So I think you should have them in the lab and you should try them. Thank you for your attention.